So I'd like to start the afternoon session by introducing Dr. Jeff Weber from here at Moffitt, so he didn't have to travel very far. He's a leader in the field of melanoma as well as multiple clinical trials, clinical trial design. I think he just wrote an important review paper in the JCO on ethics, I think, of phase 1 trials and about,
yeah, it was,
I don't want to misstate it, but...
It was the every 10-year phase 1 position paper for...
But it was an important paper on the issue about clinical trials. So thank you very much for participating in the meeting, and we look forward to your talk.
Thank you, and thank you very much for the invitation. I am not per se a geriatric oncologist, but here at Moffitt, I would estimate the median age of our patients has got to be, and Lodovico may know, it's got to be 5 years greater than the national average. And again, as we were discussing at lunch, I see a lot of patients in their 80s, and I have a very routine way of doing a review of systems. I'll say, how's your energy level? How far can you walk if you were on a flat surface? And these people are walking farther than I am. I then ask them if they exercise, what their level of activity is. They're getting more exercise than I am. So we have lots of people in their 70s and 80s who are doing great. And at least in the melanoma biz, since the median age of onset of melanoma is about 10 years less than lung cancer, certainly less than prostate, and it's a little less than breast, the older sort of 70s, 80s population is not well studied. And I have a couple of slides that relate to that, but the challenge for us is, in this institution, we have lots of patients in their 80s, and we even have people getting into the late 80s, 90s, and you always wonder, geez, can you treat them with our drugs? And the answer, I think you'll hear, for many of the drugs that are now new in melanoma that I'm going to go over, yeah, the answer is yes. So just the usual disclosures. If anyone has questions, I'll be glad to answer outside later. So as I just implied, there are minimal data in our business that talk about clinical results and the side effects of drugs for melanoma, of which there have been at least a half dozen approved since 2011, for people in the 8th and 9th deciles of age. Yet right now, at least in this institution, that accounts for a significant chunk of our population, probably 20%. If you look at the package insert for most drugs, and again, you guys are in the business, it always lists more than 65 or less than 65, and I believe that might be an FDA requirement. So many of the data that are published only refer to, are you more than 65 or are you less? And, you know, the 75 to me or 80 is the old 65, so that probably should be adjusted. And as we were discussing at lunch, to be honest, drugs like ipilimumab, adjuvant interferon alpha, and high-dose IL-2, or TIL, which is tumor-infiltrating lymphocytes with IL-2, present some serious challenges to be able to treat someone who's over the age of 70. Whereas PD-1, PD-L1 drugs, targeted therapies, and sometimes even IPI is a bit equivocal, but the latter drugs can generally easily be used in people even into their 90s. So I'll briefly for you go through how melanoma treatment has evolved over only the last 4 years, because until 2011, for the practitioner in the community, if they had a melanoma patient, it was pretty dismal. I mean, we're lucky, or the melanoma investigators are lucky in that we always had interesting investigational drugs. I've been treating patients with IPI since 2002, PD-1 for at least 6 years, BRAF-MEK for at least 6 or 7 years, so we always had access to nice drugs on trials and had some encouragement. But for the practitioner, it was pretty dismal. But the RAS-RAF-MEK-ERG pathway became very important, and actually the data were really published in 2002, and that was in Nature by Davies. And it said there's an important signal transduction pathway, which I won't belabor. I think many of us in the room in the business understand that it's an important signal transduction pathway. And the evidence suggesting that it's important is listed on the right. You know, lots of solid tumors have BRAF mutations. Half of melanomas in general have BRAF mutations, and they are drivers in the sense that the data say that if you knock down BRAF, you'll find that clearly the evidence is that it supports its role in neoplastic behavior. Knock BRAF mutations in, melanocytes will develop transformed capabilities. And there are many drugs now that are very specific BRAF inhibitors, And vemurafenib and dabrafenib are the classics that are now approved. They can clearly arrest cell growth in vitro, in xenografts, in many different cell models. So there are lots of evidence that they'd be terrific drugs to treat melanoma and other things, colon cancers that are mutated for BRAF, 1%, thyroid papillary anaplastic thyroid cancers very commonly have BRAF mutations. So VEM and dabrafenib may get approved in other histologies also. And the early data suggesting that the BRAF inhibitor vemurafenib, otherwise known as Plex 4071, would be effective was based on a phase 3 study. And all of the drugs that have been approved have had significant phase 3 or randomized phase 2 studies that have supported their registration since 2011. So the so-called BRIM-3 study was the classic large randomized phase 3 study of either the oral drug, the BRAF inhibitor vemurafenib, which was given twice a day. It's 960 milligrams twice a day, 4 pills. Or dacarbazine, which at that point was the de facto standard of care in melanoma, a lousy drug, which frankly I probably haven't used in years. But at any rate, around the time this trial was done in 2009, 2010, that was the standard of care, especially in Europe. Straight up, one-to-one randomization stratified by stage, performance status, LDH, and where you were, because this was an international study. And if you look at the toxicities, actually it wasn't bad. If you look at the left side, looking at vemurafenib, if you look at the grade 3-4 toxicities, the thing that stood out was keratoacanthomas and cutaneous squamous cancers. So again, one of the first times that a drug used to treat a cancer induced other cancers. Obviously, this is not a common phenomenon, and about 25% of the patients who get vemurafenib as a single drug will develop cutaneous squamous cancers. And keratoacanthoma is just essentially a non-invasive but obvious squamous cancer. And these are very small, characteristic-looking lesions. Anyone who's ever seen one will not forget it. It looks like a teeny little erythematous volcano with a little white tip, which is where the keratinization occurs. And if they're in the wrong place, they need to be removed. But other than that, and having a modest level of arthralgias, nausea, uveitis, some eye issues, drug was fairly well tolerated. Comparing this to high-dose chemotherapy, it was a picnic. It was very well tolerated. And the data, the survival, that was censored at the point of crossover because you could cross over in this study because it was stopped early by the Data Safety Monitoring Committee, so long-term survival data would be not very relevant since there was crossover, but there was obvious benefit. It was 13.6 months for the Vemu versus 9.7 for dacarbazine. The hazard ratio was very favorable. It was 0.7. The p-value was terrific. So this led to its approval in 2011. So there's no question that this drug generated benefit in patients with metastatic melanoma frontline compared to chemo. And the question is, what do we know about whether it works in those who are elderly or over 65? By the way, the term elderly for someone over 65, now that I'm about to be 63, I actually find I don't know how you feel, but I find it mildly offensive. I don't feel elderly. I feel fine. I don't know how I look, but I certainly feel fine. So to say someone is elderly, which I believe is what it says in the package insert for those over 65, to be honest, I think it's nuts. So obviously you guys are in the business. One thing you may want to change is what's the definition of an elderly person to the FDA and to the pharmaceutical companies. So I actually would change it to 75 or more. Anyway, in the overall experience with vemurafenib that was summarized in the package insert, there was no difference in the incidence, severity, and quality of toxicities for those over 65, under 65. And there's a lot of unpublished data from compilations of those who were V600E mutated, which is the most common BRAF mutation. No difference in PFS, OS, response rate for those over and under 65. Bottom line being, there's no reason why you should or should not use this drug in a person essentially at any age. I've treated people 90 and more with the drug, and it's frankly pretty well tolerated. After VEM came a competitor drug from GSK, so vemurafenib was from Genentech, Roche. Dabrafenib was a drug developed by GSK, and the frontline study that led to its approval is this, again, relatively similar kind of study, but because there was such obvious positive data about vemurafenib, they used a 3-to-1 randomization, which, to be honest, was a selling point, and it was a crossover study. So once you had an approved drug that was a BRAF inhibitor, testing another one in frontline gets to be a tough proposition. Many of the patients were treated in Europe, where there was a delay in getting vemurafenib approved, and this was the sales pitch 3-to-1 randomization. So 75% chance you're going to get the good stuff, and a crossover, meaning progression-free survival was the endpoint. You could not have overall survival. And again, toxicity probably was actually a little bit better than with vemurafenib. You had fewer of the squamous cancers. It was only about 6, 7, 8%. But you began to see a few other things. Palmar-plantar hyperkeratosis is very typical for dabrafenib, but not so much vemurafenib. And you had some nausea and vomiting, which is a little less likely to occur with vemurafenib. And you had these weird fevers. So again, asthenia and pyrexia became a relatively prominent feature of dabrafenib, which you didn't see with vemurafenib. Why? Nobody knows. But actually, it's a bit of a problem. People can have periodic fevers with dabrafenib or dabrafenib and trametinib, which is the MEK inhibitor that I'll talk about in a minute. So difference in toxicity profiles. But if you look at the PFS, you don't need to be a physician to figure out it looks a lot better on the upper curve than the lower curve. And the PFS difference was 4 months. The hazard ratio that was sought after was 0.33 in the initial registration, and they got 0.35, which is pretty darn close. So the data looked very impressive. Survival was not an endpoint because this was a crossover study. This came after vemurafenib's approval, and it led to a very rapid registration of dabrafenib for metastatic melanoma frontline that was BRAF V600 mutated. That's the most common mutation. Virtually all the mutations in BRAF are at the V600 locus. There is also a MEK inhibitor because, as I told you, there's the RAS-RAF-MEK-ERK pathway. So it is, of course, conceivable you could block the growth of melanoma cells, which are essentially addicted to the RAS-RAF-MEK-ERK MAP kinase pathway, by blocking it more distally. And there is a MEK inhibitor, and this was trametinib, also made by GSK. This was also tested for registration in a phase 3 study. And here it was a little different. As you can see, the trials are getting smaller and smaller because the expectations based on the phase 1-2 studies were a lot higher. So the bar for getting a drug registered now in melanoma got pretty high. And this was a 2-to-1 randomization versus chemotherapy, mostly done in Europe, because it got to be difficult to use chemotherapy alone in the US after vemurafenib got approved. And again, this was another crossover study looking at PFS and stratification. These were BRAF mutated patients. So again, in a BRAF mutated patient, a MEK inhibitor might work because the patient's growth of the melanoma growth is dependent on the MAP kinase pathway. If you were BRAF wild type, it would not work. So obviously you had to have the BRAF mutation, and that was part of the approval for BRAF mutated patients. And again, totally different spectrum of side effects. And again, now you're looking at hypertension, which is classic for the MEK inhibitor, not for the BRAF inhibitor. Acneiform facial rash, very common, and some liver function abnormalities. But other things that were seen with vemurafenib were not seen with trametinib, so they had essentially non-overlapping toxicities. And looking at the PFS, and your eyes are fine, the reason why there are 4 lines instead of 2 lines for the trametinib versus chemotherapy is that the FDA asked, in a very interesting way, for investigator-assessed PFS versus centrally assessed PFS. And because they overlapped so well, obviously these lines are almost totally overlapping, the FDA said thereafter for melanoma registration trials they would accept investigator-assessed PFS, which I think is reasonable and totally appropriate. So again, if you look at the hazard ratio, it's great, it's 0.44. The median for chemo here was a little worse. It was 1.4 months median PFS, but obviously superior PFS for trametinib. The drug obviously works. There was evidence of a survival advantage, even in spite of the crossover. So if you talk to your statisticians, anyone who does large randomized trials, a superior drug will even shine through in the presence of a crossover when you look at survival if it's a really good drug. And in fact, I don't have the survival data, but the survival curves censored at the time of the crossover looked very favorable. So other issues began to surface as we treated patients with BRAF and MEK inhibitors, and that is, it turns out that if you're a young person and get melanoma, you actually do a little bit worse in terms of outcome if you're, say, diagnosed in your 20s than in your 60s. And the patients who are BRAF, 100% BRAF mutation between 20 and 30. Very interesting. The biology is completely different. If you're over 65, it's less than 50% likely, and with each decile of age, it drops, so that if someone, say, were 80, they'd have about a 25% chance of being mutated. Like I said, if you're 25, we see a patient who's 25, we'll actually treat them with drugs without testing them, because the likelihood is almost 100%. And you have to be careful, because if you treat a BRAF wild-type patient with BRAF plus MEK or BRAF alone, you will actually promote the growth by paradoxical MAP kinase signaling. And then well established by folks at Memorial and at UCLA, you don't want to treat someone who's wild-type with these drugs. Big mistake. So, but the realization was the biology of the disease is different, and it turns out that the type of mutations are different. If you're over 65, the likelihood of a V600K mutation, which is a little less susceptible to BRAF inhibition, is higher than, say, if you're 25. If you're 25, 100% of those patients will be BRAF mutated. They will virtually all be V600E, which is the one that best responds to inhibition by a BRAF inhibitor. If you're over 65, about 20-30% are V600K. The explanation, unclear. Why someone my age would be 40% likely to be mutated, whereas someone 25 would be 100%, completely unclear. But I guess in some ways it's good, in some ways it's bad. The biology of melanoma in the young population is very aggressive. Biology of melanoma in the older patients is a little less aggressive, but they have access to a better drug when they're younger, because BRAF-MEK is a very good combination. So that brings us to BRAF-MEK. So again, the idea in vitro was if you combined inhibitors at different points along the MAP kinase pathway, you had superior killing and you overcame resistance to BRAF inhibition. Because if you take cells and plate them in a petri dish and constantly expose them to a mid to high dose of a BRAF inhibitor, eventually you will grow out some cells that are resistant. And there's been a lot of literature on the resistance mechanisms, and a good chunk of them come from mutations that arise in MEK. Many of them arise in other bypass pathways, because remember, the MAP kinase pathway is a cascade. So if you develop the generation of a substance, and COT, for example, is one of them. It's a gene that encodes a protein that allows one to bypass the blockade of BRAF and MEK and stimulate ERK to force the tumor cell to grow. But plenty of the resistance was accounted for by abnormalities in MEK. So if you had a BRAF mutation, you gave a BRAF inhibitor, and then you inhibited MEK downstream, it might be more favorable, and it certainly worked out in xenografts and tissue culture. And this was tested in a large study, and ultimately it came to a phase 3 study. And this was dabrafenib plus trametinib versus vemurafenib. The vemurafenib was the standard of care at the time. Dabrafenib, trametinib, obviously it's a head-to-head trial against the standard. Dabrafenib, trametinib in a randomized phase 2 was highly favorable, gave outstanding survival. We actually were the biggest contributors to the original phase 2 study to show benefit with the BRAF-MEK combo of dabrafenib, trametinib. But the drug's approval was cemented by this large phase 3 study. It was recently published in the New England Journal by Georgina Long. And again, it's pretty much a head-to-head phase 3 study, BRAF-MEK, both drugs from GSK, versus VEM, which is the standard, or was the standard of care, from Genentech. And there was an interim survival analysis, and there was a final survival analysis. And again, it was stopped at the interim analysis. It was so obviously favorable. And interestingly, since 2013, a lot of the large melanoma studies have started to include in the data presented the age. So again, if you look at this, again, is from the New England Journal article. Now, instead of showing it in the package insert, the differentiation of benefit by age is shown in the manuscript itself. So if you look at the hazard ratio, for the older patients, it's actually a little better for dabrafenib, trametinib versus VEM than for those under 65. So clearly, and the 95% confidence intervals overlap totally. So there's obviously no disadvantage in treating an elderly population with dabrafenib, trametinib versus vemurafenib. They do very well compared to the younger patients, no question. And again, there's another BRAF-MEK combination, which will soon be approved by the FDA. And I think we have to get there we go. And again, vemurafenib and cobimetinib are, again, VEM was the original BRAF drug. Cobimetinib is another MEK inhibitor. They're both made by Genentech. The drugs, by the way, are phenomenally similar. If you look at the survival data of VEM alone versus dabrafenib alone, they almost overlap. If you look at dabrafenib, trametinib survival and PFS versus vemurafenib, cobimetinib, they virtually overlap. But the FDA said to Genentech, well, if you want to now register your combination compared to the GSK, you have to compare it to vemurafenib, which at the time, 2 years ago, was the standard of care. So this, again, was a head-to-head trial, vemurafenib, cobimetinib versus Vem, recently published by James Larkin in the New England Journal. And as you would expect, highly favorable. They were looking at PFS and OS. Both were highly favorable compared to vemurafenib alone. And again, to my surprise, the investigators put the age differentiation into the manuscript, and it shows it here. And again, you're looking at the hazard ratio. Obviously, the hazard ratio in this direction shows the combo is better than the single drug. And as you can see, older, younger than 65, no real significant difference. Although, interestingly, same weird pattern. The over 65 hazard ratio is a little better, interestingly enough, than the under 65 hazard ratio. So again, almost as if it's a little more favorable to treat the patients over 65 who had more V600K mutations with the combination. And that's something that needs to be followed up on. But at any rate, in that trial, it will lead to the approval of those drugs in the next couple of months. The FDA is working on it. Survival was superior. They only went to the first interim analysis. PFS was superior. Amazingly, the median survivals, I think, virtually overlapped the median survivals with dabrafenib, trametinib. I'm not showing you all the data. We have other stuff to talk about. It's about 24-month median survival, which in melanoma ain't bad. And again, anyone who tells you that, well, you know, the BRAF/MEK inhibitors or the BRAF inhibitors, most of those patients eventually crash and burn and die. 24, 25 months is not a bad median survival. It's actually better than the median survival of PD-1 inhibitors, which is about 20 to 23 months. So very interesting data. So what do we say about BRAF/MEK for melanoma? Interestingly, and this has no relationship to age, you reduce many of the side effects by giving the combination. It is one of the first cases, and I think I actually presented the data at ASCO about 3 years ago. It's the first time when you actually reduce the side effects of a drug by adding another drug. Normally, you add drugs in combination, you make things worse. In preclinical models, you suppress the skin side effects of the BRAF inhibitor by adding the MEK, because you suppress the paradoxical so-called activation of the MAP kinase pathway in the normal cells by adding the MEK inhibitor. So if you look at the KAs, the keratoacanthomas, and the squamous cancers, it drops to almost zero when you add the MEK inhibitor to the BRAF inhibitor. So when you add COBI to vemurafenib, the rate goes from 25% to like 4%. Dabrafenib has a lower rate of keratoacanthomas and squames. Say it's 10%, goes down to 1%. It's actually very interesting. And it's extremely annoying to use BRAF inhibitors alone because the skin side effects can be really bad. They get papillomas on the face, they get keratoacanthomas in bad places, and they get photosensitivity. Add the MEK inhibitor, it almost all goes away. So again, same thing was seen with vemurafenib and cobimetinib. The maximal doses of these drugs were very safely combined. That's a bit unusual. Normally in a combination, you have to reduce doses. And again, as I told you, response rates, 65% for both combos, survival, PFS, virtually overlapping. Survival data look really good. 25 months is not bad. And again, with the BRAF/MEK drugs, you get more pyrexia and asthenia. And sometimes people can get really bad fevers. The classic is patient's been on treatment for 2 months. You get a phone call on Saturday morning that there's a fever of 103, and the patient feels terrible and can barely get out of bed. So what you do is they hold the drug for 72 hours. You put them on a Medrol dose pack, and 2 days later, Monday morning, they're fine. And Tuesday morning, they go back on drug, and they do fine for the next 3 months. And then the same thing happens. And I have one patient that periodically, every 3 months, gets a fever, and I have to hold the drugs, put her on a Medrol dose pack. And there are folks working to understand this. It's obviously an immunologic mechanism, or else it wouldn't go away with steroids. So very bizarre. But if you look at the totality of data, BRAF and MEK are going to be tolerated, just like BRAF inhibitors alone, in anybody at any age. So you should not hold back, even in a 90-year-old, in treating them with BRAF plus MEK. So again, there's no evidence that the type, quality, intensity of any side effect with VEM, COBI, dabrafenib, trametinib is different for those over or under 65. And again, as I told you, the primary side effects of the BRAF inhibitors alone are skin-related. That tends to diminish completely when you add the MEK inhibitor. BRAF-MEK is the standard of care. I never, ever use dabrafenib alone or vemurafenib alone. The only time we would ever use VEM alone is in a combination in a study, and we actually have a couple of SPORE studies. But the era where we would use BRAF inhibitors alone has basically disappeared. So again, the message is below in blue. BRAF-MEK should be used in anybody at any age who has metastatic melanoma. So those are the targeted drugs. The big work now in targeted therapy is understanding how to overcome resistance. So we have a trial of BRAF plus HSP90 inhibitor. There's BRAF plus MEK plus PI3 kinase inhibitors. People are now doing triple. And, you should realize that the cost, the wholesale price of BRAF-MEK is about $16,000 a month. I think one is $7,000 and one is $9,000. $16,000. So what's going to happen if you add a PI3 kinase inhibitor? What's it going to be, $20,000 a month? That's $240,000 a year. The average patient stays on for 6 to 8 months. The median survival is 2 years. That's a whole pharmacoeconomic question that we don't have time to deal with, but actually it's an issue. And the patients have no clue. They just go on BRAF-MEK, and sometimes you say, by the way, do you know how much those drugs cost? And they say, well, it costs me, $300 a month. That's my copay. So actually, it's $16,000 for the two drugs together per month. That's a lot of money. And when the people from Genentech ask, well, how will we differentiate cobimetinib plus vemurafenib from dabrafenib trametinib? It's approved a year later. Well, the side effects are similar. The efficacy is similar. How about cutting the price? I said, it's a capitalist system. So actually, a high-level person from Genentech called me to ask me, what do you think we should do? And I said, we live in a capitalist economy. What happens if you have, I don't know, BMW and Mercedes? You either differentiate it by the quality of the product, or if it's Kia versus Honda, you cut the price. Kia and Honda are probably not so far different in quality, but one's a hell of a lot cheaper than the other. Anyway, so those are the targeted therapies, great success. Sort of the urban legend in melanoma, though, is that you should treat with immunologic therapy first to take advantage of the tail on the curve. That may or may not be true, but as I'll show you, there definitely is a tail on the survival curve with immunotherapy that's not as evident with the targeted therapies, because almost everyone who goes on BRAF-MEK eventually relapses and will probably eventually die of treatment, although from the original phase 2 BRAF-MEK trial, I have 9 patients still on treatment out of 64 that we put on, 4+ years from initiation of treatment, all in complete remission. So could those folks be cured? And the answer is, I don't know. But as I'll show you with ipilimumab, if you go beyond 3 years, you're probably going to be cured. So again, about 15 years ago, a number of investigators understanding molecular immunology realized that T cells have agonistic molecules on their surface that promote T cell activation and function, and have antagonistic molecules, which, think of it as the brake. And even though it was initially thought, well, you really only had 1 or 2 brakes and 1 or 2 accelerators, in fact, there are probably 8 or 9 brakes, or checkpoints, as we call them, and at least 10 different agonistic antibodies. But some of them are more important in their activity in a cancer-bearing patient than others. And the first one that was explored by a guy named Jim Allison and another guy named Jeff Bluestone. Allison was then in Berkeley, Bluestone was at Chicago. Allison is now at MD Anderson. And those two may win a Nobel Prize for understanding the fact that CTLA-4, or cytolytic T lymphocyte antigen 4, is a molecule that's normally held intracellularly. So it's the little orange thing over there. And when you activate a T cell by having an antigen-presenting cell present an antigen to the T cell, you activate the T cell. It makes cytokines, it grows, it proliferates, it could become a killer cell, or it could promote antibody production by plasma cells and be a helper cell. But at any rate, at some point, you have to shut off the reaction, or else the immune system would continue forever and we'd all die of autoimmunity. So the way it happens is the orange thing, the CTLA-4, gets exported to the surface, and it leads to inactivation because it outcompetes CD28 for binding to B7. So these two interactions have to occur to activate a T cell. It's called the first and the second signals. So if you kill the second signal by outcompeting, and this leads to blocking of the signal, the CD28 binding to B7 leads to an activation of the T cell. CTLA-4 binding to B7 leads to a shutting down of the T cell, so it stops growing, it stops making cytokines. If you would eliminate the shutdown, so if you had an antibody that preferentially competed for CTLA-4, you would reactivate the immune system. Turns out in the cancer-bearing state, you have lots of CTLA-4 expressing T cells, especially in the tumor, not so much in the periphery. So it's essentially the brake is overly expressed. So if you could kill the brake, that's what an antibody might do. And in fact, in animal models, it worked like a charm. And you could take tumor models in mice, and you could have obviously a progressively growing tumor. And then if you gave an antibody to the mouse that blocked CTLA-4, just that manipulation would actually cause regression and cures of murine tumors in selected situations. You could give the antibody alone to mice with certain types of tumors, but if you gave it with a vaccine, it would work really well. And that has implications for future studies. So the study that led to the approval of this CTLA-4 antibody, which is called ipilimumab, which came from BMS, was a little bit complicated. There were data that I unfortunately was partly responsible for, suggesting that if you combine the antibody with chemo, it might work better than just the antibody. So the company seized upon the data and said, well, we're going to do a phase 3 study of ipi plus dacarbazine versus dacarbazine alone. So that's the dacarbazine arm, and up there is ipi plus dacarbazine. And there were also data suggesting as you jacked up the dose of the ipilimumab, which unfortunately I was also partly responsible for, it would look better than if you gave a lower dose. So they gave a pretty high dose of the antibody, 10 mg per kilogram, which is a fair bit for an antibody, every 3 weeks times 4, and then you went to maintenance therapy of the ipilimumab every 12 weeks, because if you kept giving it every 3 weeks, you were going to run into a lot of toxicity. And it was placebo versus dacarbazine because it was a blinded study. It was appropriately so. And this was a big phase 3 study, more than 500 patients. And if you look at the results, it's pretty obvious which one did better. And interestingly, this is with 3 years of median follow-up, so a very long time. Obviously, the combo arm did a lot better than the chemo arm. And even though there's a bunch of hash marks here, the data are that over a 5-year period of follow-up, everything moved this way, and the lines stayed exactly the same, so you plateaued here. Now, with chemotherapy, you may have 10% or fewer patients alive at 5 years. So this line ended up at about, I think, 8% at 5 years. This one stayed at about 20%. So 5 years later, it looked like it completely plateaued. Nobody progressed if they had been in remission, even stable PR-CR at 3 years. Nobody progressed thereafter or has progressed. So it looks like you may have cured some of the people on the plateau beyond 3 years here. And so that's not bad. And now we have like 6 and 7 year follow-up. And at the NCI, where they treated people way early on, back in 2003, 2004, so now you have 10-year follow-up, of those who had a CR, except for one patient, I think they had 18 patients in this one study, 17 of them were alive 10 years later, free of disease. So that's not bad. It is entirely possible those are cured patients. So again, a little different than targeted therapy. And if you look at the toxicities, this now shows an expanded access study where the drug was about to be approved, but literally I think something like 2,000 patients were treated in the US and Europe. It was one of the few scenarios where back in 2010, they looked at any difference in toxicities by age. There actually wasn't overall that much of a difference. If you look for any, in these toxicities of the immune drugs, so-called immune-related adverse events, IRAEs, if you look at the rate, it's actually slightly higher in those over 65 than in those under 65. It really is only diarrhea and colitis for every other immune-related event, which is hypophysitis, hepatitis, pancreatitis, uveitis, and dermatologic manifestations. There's probably no real difference. So the fact that you get somewhat more diarrhea and colitis will give you pause, but in general, I've treated people up to 90 with ipilimumab. And what I tell them is, well, there might be a slight increase in the toxicity as you get over 65. Most people in their 70s, 80s tolerate the drug very well. And the risk of a severe side effect is between 10 and 14%. And if you look at the deaths, and again, toxicity, so here, again, same study. This was done by Celeste and Rebbe. That was presented at our melanoma meetings a couple of years ago. It just got published. If you look at the deaths due to study drug toxicity, it's essentially zilch. And in the over 65 group, I don't think there was a single death due to toxicity. So what you can tell patients is that the likelihood of death or severe harm from ipilimumab does not really go up with age. Your relative level of toxicity from GI side effects probably does, which gives you a little bit of pause. And interestingly, there was an expanded access experience in the elderly that was published. And again, for our business, a little bit unusual to isolate, and these were patients over the age of 70, so in Italy they're a little more liberal with what they call elderly. And again, this was 3 milligrams per kilogram, which was not the dose used in the initial registration study. So 3 per kilogram. And so if you look at the data, the safety profile was very similar to any other safety profile in any ipilimumab study ever done. And they found that all the treatment-related adverse events in these patients generally resolved. If you look at the clinical results, these are patients who mostly had a PS of 1+. So in any expanded access trial, it's usually people who are PS of 2 that you might be treating in the real world. So if you look at the survival, it's actually pretty modest. Median survival in most studies I've done in IPI, and I've treated a lot of patients with IPI in my time, it's probably about 12 months. So here, the patients will not do as well, but it was a real-world population. But when they assayed the side effects, it was no different than anything ever published for ipilimumab in any other clinical trial. So what do we say about IPI in the elderly? There's really no difference, in my view, overall in the gross toxicity or the grade of toxicity for those over or under 65. You may get a little bit more colitis and diarrhea, but all the others, no difference. The survival does not vary by age. In my view, you can safely give IPI to someone at any age with one caveat. And I do say I've actually treated a 90-year-old who did fine with IPI. But that being said, someone who's over the age of 80 with comorbidities, I will be very, very careful about using ipilimumab, because the one patient I've seen die, and I've treated about 550 patients with IPI, one patient of those 550 died of treatment-related side effects. It was an 84-year-old who died of colitis, and interestingly, the complications of the treatment of colitis. And you have to be very careful in someone with comorbidities over 80. Someone over 80 who's in good shape, I don't have a problem. But if someone is fragile and over 80, I'd be very hesitant to use ipilimumab, because my concern is the rate of colitis and diarrhea is high, and they're not going to be able to tolerate those side effects. So the final drug, which has led to 2 approvals, and actually both approvals came in the end of 2014. One of them was in the end of September. One of them was in November or December, were for antibodies directed against PD-1, which is another checkpoint protein. So again, PD-1, or programmed Death-1, is on the T cell, and it acts as yet another brake. So what happens is, if you have its ligand, which, not very creatively, is called PD-L1, and actually there's also a PD-L2, so there are 2 ligands that bind this PD-1 receptor on the T cells. So here's the antigen-presenting cell, or actually it could be a tumor cell. And tumors, by the way, express PD-L1. Almost every tumor known to man has some significant level of PD-1 expression. In melanoma, it's about 40-50%. In Hodgkin's disease, it's very high. In bladder cancer, in gliomas. So virtually all epithelial malignancies have some level of this ligand. And what happens is, if the ligand to the brake binds it, it activates the brake. And so what happens is, you stimulate something called SHIP2, which is a phosphatase, and it kills T cell activation because it breaks up, as you can see up there, the AKT PI3 kinase pathways are important for T cells to work. By binding PD-1 to its ligand, it stimulates the phosphatases to kill the pathway. So it brings the T cell to a halt. And bizarrely, and that would make sense because you have to have some homeostasis of the immune system, right? You have to have a yin and a yang, an accelerator and a brake, like a car. The problem is, tumors hijack the PD-L1 pathway. PD-L1 is a molecule normally present on hematopoietic cells. What in God's name is it doing on an epithelial malignancy like breast cancer or colon cancer or lung cancer or melanoma, a neuroectodermal tumor? So tumors are clever, and they hijack the pathway, so the tumors perversely contain within the tumor the very means to suppress the immune response directed against it. If the tumor expresses PD-L1, any T cell that gets into the tumor will have PD-1 at the surface. they'll bind and it'll kill the T cell response. So very clever. But humans are clever too, and we have made multiple antibodies that would block the interaction of PD-1 and PD-L1. And it turns out they work really well. In fact, they work better than CTLA-4, suggesting that the PD-L1 checkpoint protein is probably the most important brake on the immune system in the setting of malignancy. And now both these antibodies are approved, and the phase 3 study of nivolumab, which was the BMS antibody that led to its approval, was again a phase 3 study, 2-to-1 randomization of nivolumab, which is the PD-1 antibody, or investigator choice chemo. This was an international study. And in Europe, they still use dacarbazine, and this was a couple of years back when this study got started. In the US, we use carboplatin and Taxol as our sort of second or third line choice. And again, in this trial, you treated until progression or unacceptable toxicity. And again, the patients were stratified by whether they expressed the PD-L1, which is sort of interesting, what their BRAF status was, or whether they had previously responded to IPI, because this was a second-line study for IPI failures. And the FDA said, okay, we also approve the BRAF drug, so if you're a BRAF mutated, you also had to have failed a BRAF inhibitor. So these are second or third-line patients. And if you look, and again, now they're being a little more enlightened in the manuscripts. We've been allowed to present the toxicities by age. If you look at the side effects by age, if you look at any grade drug-related adverse events, no real difference. If you look at the grade 3-4 side effects, there's a little bit of a difference. But looking at the grade 3-4 side effects of Nivo, either way, if you put them together, actually it's less than 10%. With IPI, it was at least 15%. So actually the drug is less toxic than ipilimumab, and it sure as hell works better because, and I won't show you the data, the response rate of PD-1 antibodies is between 30 and 40% in second line, and it's about 40% in first line, which is very favorable. And the median survival of patients who are IPI failures from that trial hasn't been reached yet. But actually, I did my own phase 2 study, an IST here, and the median survival in our study was 20.4 months, which is very good. And that was a group of patients who had failed IPI and generally had failed multiple other treatments. So PD-1 antibodies are drugs that work very well. There was another one called pembrolizumab, which interestingly was approved before, a few months before nivolumab. And this was approved on the basis of a randomized study of pembro at 2 milligrams per kilogram, 10 milligrams per kilogram, and investigator choice chemotherapy. And these data have already been published, and there was a clear benefit for either pembrolizumab arm versus chemotherapy. There was a 40% response rate, chemotherapy 10% response rate. The PFS was superior. The overall survival was not an endpoint of the study because it was a crossover study. So again, in this sort of study, in the US, if you're offering patients an immune therapy versus chemo, there's no way anyone would enroll if there were not a crossover. So PFS was the endpoint, OS was a co-endpoint, and the OS data are not even available, but the bottom line was in this study, clearly you had superiority of the PD-1 antibody at either dose versus the chemo. And again, looking at over 65, under 65, no real impact of age on PFS, no impact of age almost on any significant parameter, response rate, et cetera, et cetera. And it didn't matter whether you gave pembro at 10, pembro at 2. Ultimately, the FDA approved it at 2 mg per kilogram because the side effects were a teeny bit less, and the government figured if it's 2 and 10 and they look about the same, we'll just approve 2. So pembro at 2 every 3 weeks, nivolumab at 3 milligrams every 2 weeks were both approved at the end of 2014 by the FDA. And then finally, those were second-line trials. There's also been a frontline trial of nivolumab versus chemotherapy done in Europe. These days, you cannot do a trial of frontline treatment in the United States versus chemo. No patients would ever go on. But remember, in Europe, they were slow to approve BRAF inhibitors, and there was an interval of time where in Europe you could get away with doing a frontline trial where chemotherapy was the control arm. And this was just a straight-up nivolumab, which is the BMS PD-1 antibody, versus dacarbazine, phase 3 study. And here, primary endpoint was overall survival. Secondary was PFS. And I think you would admit it's pretty obvious, and these were data that was stopped at the initial analysis. It's pretty obvious that there's a pretty quick differentiation at week 12, which I think was the first evaluation, or week 8, which was the first evaluation. The curve split apart. And this was the first interim analysis. You have lots of hash marks, so very little follow-up. But it's pretty obvious that you do a lot better. The response rate was something like 39% versus 10%. The overall survival at 1 year, obviously very impressively different. The p-value was very, very good. So this will eventually lead to its first-line approval. This was a study done in Europe, because again, in the US, you could not have done a frontline study with chemo. This will essentially put to rest anyone who ever does a chemotherapy-controlled frontline study. It just will never happen again. So this was the last trial of that type. And interestingly, if you look at the PD-L1 staining, so this is an ongoing story. I told you PD-L1 enables the tumor to hijack this pathway. You figure if a tumor didn't have PD-L1, the antibody wouldn't work. Interestingly, that's not true. If you look at the response rate in those who have PD-L1, very good, very nice numbers. But you can still respond, although at a lower level, if you're PD-L1 negative. Now, you could argue immunohistochemistry, which is the assay used, may not be that accurate. You might really have PD-L1 here. But still, both I and many others have done trials where we've looked at PD-L1 staining. There is an association between PD-L1 positivity, but you can't use it as a predictive marker. Because what's a predictive marker? You're going to test it before you start and tell the patient who's negative, sorry, you shouldn't get this drug. With BRAF mutation status, absolutely appropriate. If you had BRAF wild type, I would not put you on a BRAF drug. If you were PD-L1 negative, I'd still treat you with Nivo. And if you combine IPI and Nivo, it doesn't matter whether you're PD-L1 positive or not, the response rates and the survivals are the same. So we'll conclude with IPI and Nivo because now all the work in melanoma is combination studies. Nobody's using any single drugs anymore unless it's a first-in-human phase 1. And Jed Walchuk published already a year and a half ago a combination study where they looked at the PD-1 antibody nivolumab with the CTLA-4 antibody ipilimumab. And if you look at the waterfall plot, it looks pretty darn good. The response rate was 43%. The waterfall plot was incredible. 80% of the patients had some evidence of regression. It looks like a vemurafenib or a dabrafenib-trametinib waterfall plot. Very impressive, and you had rapid responses. And if you look at the swim plot, almost everybody still has a black arrowhead, meaning of the patients who got concurrent therapy with the 2 drugs, almost everybody, with modest follow-up, has stayed in remission. And the updated survival data will be presented at ASCO in a month and a half. And it looks pretty damn good because if you look at the interim analysis, and this is very little follow-up, just about 2 years of follow-up, 2-year survival was 79%. In any malignancy that's metastatic, those are pretty good numbers. In melanoma, that's the best we've ever seen. And this was not a tiny amount of patients. On the flip side, you have benefit, but look at the grade 3-4 toxicity rate. 62% rate of grade 3-4 toxicity. And much of it was asymptomatic. Much of it was hepatitis, elevated AST, ALT, or amylase and lipase. And it turns out that lots of patients who get these drugs have subclinical pancreatitis. And I say that because I don't know why else an amylase and lipase would go up. It ain't the parotid, and I can't think of any other organ that has amylase and lipase. So you see significant numbers of patients who have high amylase and high lipase. And the FDA is onto this, and they will actually let us treat through grade 3 amylase and lipase elevation. We just have to wait till it comes down, and then we just keep going. It is not a dose-limiting toxicity. But either way, a 62% rate of grade 3-4 toxicity is pretty darn significant. Now, I'll end up with the final treatment that you all will hear about, because it too is coming to a phase 3 study, coming soon to a cancer center in your neighborhood. And that's TIL therapy. And the TIL is tumor-infiltrating lymphocytes. And this is an incredibly complicated, on the face of it, treatment where you basically harvest the tumor. And it's not just any tumor, it's got to be about 1.8 to 2 centimeters. And usually the easiest harvest is going to be in the sub-Q or nodal metastasis. You can resect the lung met, it works very well. Every once in a while you can do a wedge resection for a liver met. You got to get tissue, you got to get a tumor. And it has to be immediately transported in the proper way, where you literally mince up the tumor. You take the tumor, you cut it up with sterile scissors and a scalpel. I used to do this for a living back at the NIH. And you put the fragment fragments into wells of a 24-well plate. And you expand them. And at some point, you actually will test them versus a melanoma cell line by taking a tiny aliquot of the cells that grow out. So interestingly, the lymphocytes will leave the tumor fragment, and they look like little arrowheads. They literally will crawl out of the tumor, and they will then kill the remaining tumor cells. And that's a sign that they're obviously tumor reactive because they come out of the tumor milieu in high-dose IL-2. Obviously, in the tumor microenvironment, they ain't doing anything because the tumor's growing. But once you put them in a plate, they will emerge from the tumor, and it's great. You watch them under the microscope crawl out. It's great. And they will kill the tumor cells. Some of them will not, and you discard them. The ones that do, you preserve and you test them, and they will generally be tumor reactive in a very small microassay. And you then pool the most reactive ones into large flasks, and you add OKT3, allogeneic feeder cells, just radiated peripheral blood cells from a normal donor, and more interleukin 2, and you expand them in these Teflon bags. We now use a bioreactor to do it, which is a flask, and it's done in an incubator in a GMP lab that's used for stem cells, as we do here at Moffitt. And you'll end up getting 50 to 100 billion cells after about 5 weeks. The patients, a week before you're going to give the cells, get cytoxin fludarabine, non-myeloablative treatment, and for about a week, the lymphocyte count and the white count is zilch, nothing, 0. And it's transient. That's why it's not myeloablative. And you then give them the cells at the time they're at the nadir of the white count, so you make immunologic space, as we call it. So their only active white cells are the ones you transfer. And you then wait 12 hours, and you give them 5 doses of high-dose IL-2, given every 8 hours, and then you stop. And that's the treatment. It's a one-shot deal. And the response rate's 40 to 50%, and everybody who is in remission stays there for a long time. And this will be entered into a phase 3 study versus IL-2 alone sometime in the next year or two. And some of the data, which are very interesting, and again, this was first done at the NCI.
Please forgive my lack of knowledge, but this passes through the blood-brain barrier?
Interestingly, it does, because you give them intravenously, and there are data again, slides. But at the NCI, we used to always, again, this is where I trained, we always used to exclude anyone with brain mets. One day, a patient with a brain met snuck through, and the radiologist blew it, and he just failed to notice that the patient had a 1 centimeter brain met. Oops. Patient gets treated, does well, and then we find out about this. The boss goes crazy, he gets upset about it, but he says, fine, let's just follow, see how it goes. Brain met disappeared. So, wow, N of 1. So based on the N of 1, and this is classic, empiric medicine, he said, let's include some patients with brain mets. So they started including those with brain mets smaller than 2 centimeters, no edema, so you ain't giving IL-2 to someone with brain edema, and less than 3 total brain metastases. And it actually did not impact on the response rate. So yes, the quote, blood-brain barrier is not an impediment to the passage of effector T cells. So it actually works. Very interesting. At any rate, so here, and again, this is a bunch of patients treated at the surgery branch of NCI. I think there's 70-something patients. You're now looking at a plateau out at 5 years of about 30%. So that's not bad. And of those who had a complete response to TIL, these folks, almost all of them are alive and in remission. I think they had some 7-year follow-up data recently published in clinical cancer research. So again, very selected population. Not everyone has a 2 centimeter met. Not everyone is 70 or less and able to tolerate high-dose IL-2. But again, you're going to hear more about this. So conclusions, and I'll just reemphasize on a couple of slides. Targeted drugs like VEM, dabrafenib, trametinib, you can give these drugs to anybody. You can give them to 90-year-olds. The cutaneous manifestations still exist with the combinations, and they're going to get worse with age because getting squames doesn't drop to 0. It's down to a couple of percent. It varies with your sun exposure. Obviously, the older patients will have had more sun exposure. IPI and PD-1 antibodies can be given to very elderly patients, but I would be cautious about giving IPI to anyone with a borderline status who's over the age of 70 who has comorbidities. Again, very difficult because they're not going to be able to handle colitis, and then if they get colitis, they get high-dose steroids. It can be a disaster. Unfortunately, in some ways, the elderly are disadvantaged with the BRAF inhibitors because BRAF status changes with age. Why, we do not know, but it's the inherent biology of melanoma. The only concern about the targeted drugs is sometimes you get these debilitating fevers with dabrafenib, trametinib, Interestingly, doesn't happen with vemurafenib, cobimetinib. There you get hepatotoxicity, but you don't get the fevers. So pick your poison. And again, the concerns in those over 65 about tolerating checkpoint protein inhibition is the two most dangerous side effects are colitis and pneumonitis. And with the PD-1 antibodies, you can get serious pneumonitis 1% of the time. And thank God I've never seen a patient die from the effects of pneumonitis, but I've seen 3 people in the hospital sick as hell. If you have lung cancer and you get pneumonitis, you got a big problem. So you have to be very careful in the older patient. If they're borderline, ipilimumab may not be the drug for them, and ipi-nivo may definitely not be the drugs for them, because the combos are going to have higher toxicities and are going to present some serious challenges. You're going to have to handle the combos very carefully in the elderly, and I think we're going to have to treat the toxicity differently. So we actually have done a trial where we looked at the side effects of concurrent ipi-nivo and said, why don't we try doing it sequentially? A, B, B, A. And actually it was much better tolerated, and we don't have the survival data, but we'll know this for ESMO coming up in September. It may be just as good, and if it is, it would certainly be better in an elderly patient to give sequential immunotherapy, not concurrent, because it's just less toxic. And we have like 0 PK data on these drugs in the elderly population. And bizarrely enough, sometimes immune senescence, which is a real phenomenon in those over 75, may attenuate some of the side effects of the immune agents in the elderly. And again, giving adoptive cell therapy or high-dose IL-2 in someone in the 8th or 9th, 10th decades, I think is a crazy thing to do. That's just not going to happen in the future. And then I have a case, and I guess, Lodovico, should we do our case later? Because we had time for...
No, you could do your case now. You just...
I just have a question. What happens if you treat them, have you tried to retreat these patients at progression?
So you can, if you respond to IPI or have stable disease for at least 24 weeks, the rate of re-stability or re-responding once you progress is actually about 45%. With nivolumab, again, much less experience. With nivo or pembro, if you have a response, go off treatment at, say, 2 years. Most of the trials will go for 2 years. And then again, 6 months or more later, progress. Same thing, you have a very high rate of respond. So very interesting. And again, all the work now is what are the predictive markers for success? Because if someone's never going to respond to nivo, you want to know. So how can you pick the ones who are going to respond at the get-go? And PD-L1 staining is not adequate. And then what causes resistance? Other checkpoint proteins? It's going to be hard to figure it out.
Okay. Tell us about between 2 milligram and 10 milligram doses, whether one of them came out better.
Survival curves overlap. P-value is like 0.8.
So the bottom line is...
And the toxicity was a little bit worse, so the company, Merck, decided, well, we're going to go with 2. So they submitted 2 for registration to the FDA. Actually, it was not 89 patients. The original registration was based on 89 patients, and they had breakthrough approval. Right? When you get breakthrough approval, that means you generally get an approval based on the phase 2 study. And this was second-line patients, and it was 89 patients with a very good response rate. It's like somewhere in the mid-20s, 24% response rate with 89 patients. About 50 year U.S. included, and they didn't have a control. It was the original trial that preceded the one that I showed.
Mhm.
It was Pembro at 2 and Pembro at 10, just a randomized phase 2. And they later did 2, 10, dacarbazine.
Yeah,
The FDA
sure.
required a repeat trial. So I showed you the design of the
Right.
trial. The original trial that led to Pembro being approved was a 170 patient randomized trial. 89 patients got 2, 80-something patients got 10. And it was something like a 22 and a 24% response rate for the first time. So they were very smart. They got breakthrough approval, which means they didn't have to do phase 2.
Right.
So they actually got their drug approved in September of 2015. BMS did a standard phase 3 study that we showed. That took them until December.
So where would today anybody use DTIC?
That was desperation. I don't know, as I recently told a reporter who was asking the same question, I said, chemotherapy for melanoma, hopefully the go later the better. So you would generally almost never use it. In a rare patient,
How practical is it to get BRAF results back right away?
It takes, you can do it in its chemical stage, roughly in 2 days. Then we have about a 5-day turnaround to get the results. So what happens is everybody gets the next genome sequence of when they had stage 3 melanoma, with suspected memory-free disease. We get the data, it's in the bank, and God, if they relapse, you'll know.
But you suggested that BRAF might have to be repeated because it can change.
No, actually, I didn't say that. BRAF doesn't change. If you take a lesion at stage 3 with BRAF, it's 99% important to the primary metastasis. So is it possible if you have 10 lesions that 9 of them would be mutated and 1 not? There is some heterogeneity. So if you diagnose at a certain point of stage 3 disease, and you're mutated, you always mutate.
Quick question. Have you used liquid biopsies, i.e. Guardant or other approaches for detection of BRAF in individuals that you don't have adequate tissue? Although I guess with melanoma, you probably always have archive tissue.
Always going to have adequate tissue. And the answer is yes, it works. We have a guy here in Smalley who looks on that here. But these assays will work. You can either look for DNA in the circulation in the serum, or you can look for circulating cells, and yeah, you can do that. And, you know, a nice thing to do is to monitor that and find out whether it can give you an early assessment of resistance. Let's say a MEK1 mutation is so you have a panel of mutations you can look at for resistance, and if you detect them early, is that can help you? I guess it would help you switch to a different treatment. That also means you can have other alternative treatments available. But it works.
All right, Dr. Weber, thanks very much. Kind of have to move along. That was great. It's a lot of exciting stuff in melanoma, that's for sure.